I'm Dr. Reema Mirza, and we'll be talking about psoriasis today. Now, what is psoriasis? Psoriasis is basically a papillosquamous skin disease, and it is a chronic genetically determined inflammatory skin disease. It is characterized clinically by well-circumscribed erythematous plaques bearing silvery scales on them, and it mainly involves the extensive surfaces in the scalp. Now, the classic lesions of psoriasis are that these are erythematous, salmon pink colored plaques, and they are present mainly on the extensive surfaces of the body, like the elbows, knees, and other extensive surfaces. Also, one of the features of psoriasis is that the lesions are symmetrical. That is, if lesion is present on one shin, it will also be, in majority of the cases, it will be also present on the other shin. Right? So, now what is the etiology of psoriasis, and what are the provocative factors which aggravate psoriasis? Now, psoriasis is basically genetic, and there are certain factors which aggravate psoriasis, like any sort of stress, which may be infection or any other stress, emotional stress, surgery, or whatever. It may result in the aggravation of psoriasis. Also, sunlight aggravates psoriasis, trauma, certain endocrine factors. Pregnancy, it is generally seen that in pregnancy, 40% of the cases, they improve, patients of psoriasis, they improve during pregnancy. Whereas in 15% of the cases, there is bursting of psoriasis in pregnancy. As I mentioned earlier, stress of any sort may result in aggravation of psoriasis. Then certain drugs may aggravate psoriasis, like lithium, antimalarials, beta blockers, ACE inhibitors. Steroids also, when they are used in excessive amounts, maybe even topical, and then you suddenly withdraw the steroids, that may aggravate psoriasis, and it may lead to a very severe form of pustular psoriasis. Then other infections like AIDS, and certain lifestyles like smoking, alcohol intake, these factors may also result in aggravation of psoriasis. So here are some of the characteristic lesions. Here you can see these plaques. They are present on the extensor surfaces of the arm. These are well demarcated plaques with scales on them. Right? These are silvery scales on them. And the characteristic lesions may vary in size and configuration. Here you can see they are of various size. Then these are sharply demarcated. Lesions are of salmon pink color. Salmon is basically a fish. The lesions are of salmon pink color. This color is basically seen in white skin individuals. In our pigmented skin, these lesions may be somewhat darker in color. Then they have silvery scales on them, and Auspitz sign is positive. Now, what is Auspitz sign? Auspitz sign is when you scratch these scaly lesions, the new scaly lesions, their bleeding points can be seen here. And this is known as the Auspitz sign. Why this occurs? Because in case when you see the histology of psoriasis, there is suprapapillary epidermal thinning, and there is dilated blood vessels in the dermal papillae. So the dermal papillae, they are invaginating, going inside the epidermis, and there is, above these papillae, there is thinning of the epidermis. So when the lesion is scratched, the epidermis, there is an erosion, and the dilated blood vessels, they are exposed, and that is why we get those bleeding points, which is known as the Auspitz sign. Now, the preferred sites are the extensor surfaces. There may be involvement of the lumbar area and also of the scalp. Now, some lesions of psoriasis. Here you can see the scalp involvement. In case of scalp, this is the hairline, and you can see the edge of the plaque beneath the hairline. This is a very good sign which helps in differentiating it from other scaly conditions of the scalp, like dermatitis or fungal infection. You can see in majority of the cases, the edge of the flower beneath the head. Also here you can see these flowers with silvery scales on them present on the extensor surfaces. Now the nails may also be involved in case of psoriasis. There is pitting, there is ridging, there is onycholysis, there is destruction of the cuticle, right? So there may be paronychia, so there is subungual hyperkeratosis, oil drop sign. All these are the features of nail psoriasis. We'll be discussing them later also. Now, there are a number of types of psoriasis. So we'll be discussing the guttate psoriasis, nummular, leukoid, flexural psoriasis, pustular psoriasis, erythrodermic psoriasis. Then in atypical forms, we have linear psoriasis, seborrheic psoriasis. There may be scalp involvement of the palms and soles, nail changes, and tuberous phenomena. Now, in case of psoriasis, what we have discussed up to now is that they are mainly present on the extensor of psoriasis involves the flexural areas also. When there is involvement of the flexural areas, parts are not that thickened, and in majority of the times you don't see the scale because there is friction at that site. And like for instance, in case of groin area or inguinal area, or there is friction plus some moisture. So in majority of the cases, you don't see the scales, but you do see the plaques. Then this Covenus phenomena, this is basically when injury is produced on the skin of psoriasis. At the site of injury, there is development of the psoriatic lesions. This is known as the Covenus phenomenon. This is also seen in other conditions like planus and vitiligo, etc. Now, taking one by one, first we'll discuss the guttate psoriasis. In case of guttate psoriasis, what happens is that there is a shower of small lesions. These small plaques can be seen. Shower of plaques like the raindrops. And this usually occurs with foot infection. And it is particularly seen in children and young adults. So here, you can see these small plaques with fine scales on them. This is known as the guttate psoriasis. Then this is the nummular psoriasis. They are well-defined, different sizes, oval or irregular in shape, single or they may be multiple. And in majority of the cases, when they are present in the multiple, they are present symmetrically. Here you can see these nummular lesions of psoriasis. This is the extensor surface of the elbow. Annular psoriasis, these are annular lesions and they have raised borders. This is also a morphological variant of psoriasis. Then we have this elephantine psoriasis or leukoid psoriasis. Excessive scaling occurs here. Limpet cone-shaped like lesions. They are very persistent and they are thickly scaled and hyperkeratotic. Then we have a severe form of psoriasis that is known as the pustular psoriasis. There are two very severe forms of psoriasis. One is pustular psoriasis and the other is erythrodermic psoriasis. In case of pustular psoriasis, we have sterile pustules that are present very superficially. They are limited to stratum corneum and they are sterile, that is, they are not infected. And these may be localized, like confined to the hands and feet, and they have a chronic course and very resistant to treatment, the localized form. Then there is a generalized form. It may involve the whole of the body, and it may be subacute, acute, and this psoriasis is pustular psoriasis is a life-threatening condition. Why? Because these pustules are very superficial, and once they are formed, they easily get ruptured. And when they get ruptured, there is erythema behind these. Excuse me. ये एक्सक्यूज मी, पीछे से प्लीज आप लोग बहुत शोर कर रहे हैं. एक्सक्यूज मी, पीछे से शोर आप लोग बहुत कर रहे हैं, डिस्टर्बेंस हो रही है. Okay, sorry, there was some disturbance in the class. Hello?
जी मैडम.
हाँ, जरा फिर से करें, पीछे से इतनी शोर कर रहे थे कि वो कंसंट्रेट ही नहीं हो पा रहा.
जी जी
ठीक है, अब इसको रिज्यूम कर दें.
ठीक है.
स्टार्ट करूं?
जी जी.
Okay, so we were talking about pustular psoriasis. This is a life-threatening variant. Why? Because the pustules are very superficial, and once they are formed, they get ruptured, and then there is erythema behind it, and the patient develops erythroderma. And erythroderma again is a life-threatening condition. The pustular psoriasis, the symptoms are that the patient is very is uncomfortable, and when these pustules they erupt, there is a burning sensation and discomfort among the patient, right? So when these pustules they get ruptured, patient there is erythema behind, and in majority of cases, more than 90% of the body surface area is erythematous. So that is known as the erythroderma with all its complications. Now this is erythroderma. There is involvement of more than 90% of the body surface area with erythema and fine staining. Now why do I say that erythroderma is life-threatening? Because there is increased blood flow to the skin, and there is loss of heat resulting in hypothermia. At times, the scales, they block the sweat ducts, and they result in hyperthermia also. Then there is electrolyte imbalances. There are more chances of infection. Excessive scaling results in loss of iron and loss of proteins. Factors lead to hypoproteinemia or hypoalbuminemia. There's peripheral edema. There may be right heart failure. So these are all complications of erythroderma, and this again is a severe form of psoriasis. ये आगे नहीं जा रहा है
मैडम. उसको क्लिक करें, उस पर ये फुल स्क्रीन करिएगा. क्लिक करेंगे एक दफा, कर सकते पॉइंटर से क्लिक करेंगे, फिर नेक्स्ट से कर लें एरो की से. देखिए, इस पर क्लिक करें, स्क्रीन पे क्लिक करें अपनी प्रेजेंटेशन पर.
to the palms and soles, and here you can see this involvement may present as typical plaques. Less well-defined plaques may resemble lichen simplex or hyperkeratotic eczema. So there may be involvement of the palms and soles also. Here you can see the nail plate involvement, and here you can see this pitting is there. You can see here the onycholysis, and here also you can see the ridging. The pitting and ridging may result in roughened nails, and there may be crumbling of the nail plate. Then here you can see this oil drop sign. This is basically because of the psoriatic plaque on the nail bed. And there may be onycholysis. Another change is the subungual hyperkeratosis. Scaling ultimately results in the shedding of the nail, which is the onycholysis. Then you may also see splinter hemorrhages in the nails. Now, in case of psoriasis, there may be joint involvement also. So, one of the radiological classification we consider in psoriasis is the Moll and Wright classification, according to which the types are that there is a predominantly peripheral mono or asymmetrical oligoarthritis. Then there may be predominantly distal interphalangeal arthritis. There may be symmetrical rheumatoid-like rheumatoid factor negative polyarthritis. Then there may be a type which is the arthritis mutilans. And there is a type which is the predominantly axial arthritis. Also, there may be cervical spinal involvement in case of psoriasis. So, how do you diagnose psoriasis? Diagnosis of psoriasis is basically clinical, and if there is difficulty in coming to a diagnosis, we can go for a biopsy of the skin, and the psoriasis has a very typical biopsy, and that can help in the diagnosis. There's no lab test as such which would diagnose psoriasis. Now, coming to the treatment of psoriasis, since psoriasis is something which is not curable, the treatment should be as conservative as possible. When the severe form is there, then we have to go for systemic therapies. We have to be careful regarding treatment with systemic therapies because systemic therapies, almost all of them are cytotoxic drugs and they have their side effects. And the patient has remissions and relapses. So every time if the disease can be controlled with the topical option, that is better, because every time we give systemic therapies, it may have side effects, right? So amongst the topical options, we have emollients. Topical steroids can be applied, but these should not be very potent, and mild steroids, and they should be applied for a short time. Then we can go for vitamin D analogs like calcipotriol, calcitriol, calcitol. Coal tar can also be used. This is basically a keratolytic. Also, salicylic acid can be used. These are basically keratolytic options. Then topical calcineurin inhibitors like tacrolimus and 5-macrolimus can also be given. Then we have an option of the phototherapy with the UVB therapy and HUVA therapy. HUVA therapy is basically where we give oral sorrel and then expose the patient to ultraviolet A radiation. Right? So this is one of the options. Then amongst the systemic therapies, we have methotrexate, cyclosporin, acetretin, hydroxyurea. Now, methotrexate is a folic acid antagonist, and it is required for the maturation of the cells. And when this is given, this results in decrease in the proliferation of the cells. So this is basically what is happening in psoriasis, that there is excessive cell turnover. So methotrexate is one of the options, but we have to be careful when we give methotrexate because it has side effects on the liver, especially, and it may result in liver fibrosis. So this has to be given very carefully in alcoholic patients. The other options include cyclosporin, acetretin, which is a retinoid, vitamin A derivative, hydroxyurea can also be given. If the disease cannot be controlled by these, then we can go for biological therapies like etanercept, secukinumab, adalimumab, infliximab, etc. These biological agents are basically cytokine inhibitors, and they can be given in cases, especially they have good results in case of psoriatic arthritis. Right? So, various therapies that can be given and their efficacies. Phototherapy, UVB and emollients, it has good results. Photochemotherapy, that is, we give sorrelin and then expose the patient to ultraviolet radiation. It has good to excellent results. Methotrexate, which is a folic acid antagonist, required for the maturation of DNA and proliferation, inhibits the proliferation of cells. This has excellent results, but again, certain limitations. Retinoids like acetretin, etretinate, these given options, they have fair. Methotrexate can be given along with the pure therapy, and this results, excellent results are there. And retinoids can also be combined with the pure therapy, which is known as the re-pure therapy, and this has excellent results. Also, cyclosporin can be given, and this has good to excellent results.
जी मैडम।
जी कोई सवाल होता है उनको?
मैडम देखिए, आप है ना ऊपर की तरफ जाएंगी ना अपने
जी
माउस लेके, तो देखिए मोड लिखा हुआ आएगा। मोड को जैसे ही खोलेंगी ना तो चैट
जी
लिखा हुआ आएगा, चैट को ऑन कर ले। वो चैट
हाँ,
पे क्लिक
चैट
करें, चैट जी हाँ ऑन हो जाएगा
चैट
चैट।
तो आ गया मेरे पास।
जी जी बस हाँ, ये जो भी क्वेश्चन हो यहाँ से करेंगे, आप है ना जवाब दे देगा। ये मैसेज पे क्वेश्चन करेंगे, आप है ना वैसे जवाब दे देगा
जी
मैडम।
जी। Pure therapy is basically there you give oral sorolin. Sorolin capsules are available. These capsules are given to the patient, and then the patient after 2 hours is exposed to ultraviolet A radiation. ठीक है, अल्ट्रावायलेट ए रेडिएशन जो है 2 घंटे बाद हम इसलिए करते हैं ताकि जब सोरोलिन का कैप्सूल दे दिया जाए तो उसके बॉडी में स्प्रेड आउट होने के लिए it needs some time. So after 2 hours we expose the patient to UVA radiation. UVA जो है ये आप चेम्बर में दे सकते हैं, या आप चेम्बर के बगैर भी हैंड UVA रेडिएशन थेरेपीज आती है, वो भी आप कर सकते हैं। ठीक है, so basically you give oral sorolin and then expose the patient to ultraviolet A radiation. So this is pure therapy. Any more questions?